morning, everyone. I think we probably should get started. Thank you all for coming today. Elders, ladies and gentlemen, colleagues, friends, welcome. Just before we get going, I have a few daily announcements. As a courtesy to our presenters and to the audience, I remind you all to turn your cell phones off. And I also remind you that we're encouraging people to submit feedback and the evaluation, which is online as part of the app. So you're welcome to use that. My name is Robin Roots. My grandparents come from Scotland and from England, and I currently live on the traditional territory of the Lheidli T'enneh, which is near Prince George. It's my honor today to extend a very warm welcome to Elder Rose Marshall. Rose is a First Nations elder from the Enoch Cree Nation, which for those of you, for the Cold Lake First Nation, which for many of you is very close to here. She's a community health representative and has graciously agreed to open this session. Rose. I'll also invite Sarah to give a traditional gift to Rose.
Thank you, Robin. Rose, please accept an offer of tobacco for your presence today and sharing with us. I will leave it on your, and this was grown in our garden. The tobacco seed was originally given to me by another elder in Saskatchewan. So, okay. Thank you.
Thank you. Thank you. Salot ina. Senior si John in Daily or Untitled 36 territory Julia John. Godat Yazos no help. Sorry, Simale Kalo Soar in Lotwazan. I say welcome in my language to the Treaty 6 territory. And I know you don't understand what I said, but I said I welcome all of you in my language. So with that, if you will all stand, we will do the opening prayer. And when I do my prayer, I always encourage all of you to join me in however you say your prayers. I pray in my language because that's what I was taught by the elders. When you're asked to pray, you pray in the language, in our language. And it really is powerful. And so with that, I encourage all of you to join me and ask for those things that you need, to take home from this conference here. And I wish all of you to have a real pleasant visit to Edmonton. Sedari hons en ek emasin en essensi. Ni jondan ekal na destiana sin lai. No kan ila hora lunes Canada Heidli. Ots anots ninu daily ja. No sanen nila. Sanen winning deod andu els arahidi wale no sanen nizi Donald do. Rid adana da yai hora lun. Betsahidi ha na winning twen. Jonsi anna det hulunes so no hal nuni ande begagid dale. Etanigid lo hanithilio els ahidi udarid da hacha. Kudaiha, und other said Zeget la Masi in essence. Say Dariye Masi Chok. Hi. I'm going to tell you a little bit about myself. You can sit down. I started out as a young child and always wanted to be a nurse. So I had an opportunity to make an application to go to school in Calgary. But my dad found out I was only 16 and he said, "You're too young to leave." So I got married at a very young age and always wanted to be in the health field. So I had an opportunity to take a community health representative training, and this happened to take place in Moose Factory, Ontario. Now I live in Cold Lake, which is, convenient to stores, and you go someplace, you jump in your car and you go. But out there it's different, you're totally isolated place. So that's where I began my life working in the health field. I worked on the reserve many years. I came to the city and in 1976, and I worked as an urban health worker. That was connecting our people to the proper services, in the city. I had to learn all that myself. But I was lucky because I had a lot of people to help me. I just started working with everybody like a friend would, and that lifestyle really helped me open a lot of doors for me. I had an opportunity to grow, learn in life, and to make my story short, I ended up helping the university and the Faculty of Nursing here in access to health services research. We did 2 projects. These are our people using the emergency at the hospitals. We did one at the university and one in the middle of the province, which is Wetaskiwin. So those, we put a CHR in there to find out what our people were experiencing in these places. And it really worked good because our people using these facilities realized, hey, there's a Native person working here. And so it opened a lot of communications for them, and it worked really good. So to do our evaluation, we had students from with Obima act out what the data collection, we collected, and the students acted out to do the report, and it went over really well. So, of course, the money ran out, but I still go and help them whenever they need me. And one of the other thing that I like to talk about is, my father died in a house fire in 1973. And at that time, I was working at the AIDS Network in Edmonton. And my world fell apart. I tried to connect with people who would really help me. And I didn't find, the kind of help that I wanted from our people. So I started putting all my knowledge together with all my training. I'm a life skills coach. I took Nietzsche courses. And so I put a program together for family units. So I do loss and grief for family units. And that really works good for, trauma cases and stuff like that. So that's what I do. Plus, whenever I get called to help, I'm just happy doing this. And I want to say welcome to Alberta, and I hope you enjoy the conference and take away a lot of knowledge. And I'm just playing a little small part of this. Okay, thank you.
Thank you very much, Rose. We're very honored to be on your traditional land, and thank you for your words that certainly put today's talk into context. Thank you. It's wonderful to hear your experiences. Thank you. I'd like to take a moment to just share another tradition with you that belongs to the CPA and certainly is part of the land that I come from, and that is of a traditional talking stick. I don't have enough hands here, but this traditional talking stick was given to the CPA on the event of Congress being held in Victoria. It was carved by Jim Yelton of the Coast Salish on the West Coast. And the talking stick represents order and respect. And this talking stick has on it the hooves of 4 deer and an eagle. The eagle represents that respect, and the 4 hooves of the deer represent the order. The name of our talk today is Passing Around the Talking Stick, which is part of her tradition of sharing stories and sharing perspectives. So I now turn this over to Moni, who will take us through.
Good morning, everybody. My name is Moni Frick, and I am happy to be here on Treaty 6 land. I come from traditional Treaty 1 land in Winnipeg, and I'm a child of German immigrants. And so most of my teachings in Aboriginal health come from the OJ Cree in northern Manitoba. We have a variety of presenters today, and each of us will introduce ourselves as we go, so you can put a face to a name. And also, I think before we proceed, we'd also like to acknowledge and thank the Global Health Division that invited us to do this talk today on Aboriginal health issues. So, welcome. We're already into the outline. We've already did a bit of a welcome. I'm going to start with a bit more of an introduction and introduce the newest position statement of the Canadian Physiotherapy Association on Aboriginal health. So we're going to highlight some Canadian initiatives to promote Aboriginal health from the academic, from the clinical, and from the research perspectives. And then hopefully we will have enough time to do some sharing of stories with you in the audience. So in the way of an introduction, we felt very strongly, the group of us who are from all across Western Canada, that we wanted to come at this not from a deficit model, but from a strength and abilities sort of perspective. But I think that we all acknowledge when we're talking about Aboriginal health issues that if you don't acknowledge the determinants of health, then really it's you're not doing justice to what's going on. We know that they're not experienced equally in Canada for a variety of population groups, but of course we're focusing specifically on the Indigenous peoples of Canada today. So we know that access to equitable health, education, employment, and social services are not experienced the same by people across Canada, whether it's between neighborhoods or between provinces or between territories, and that the experiences of gender, race, and culture are not lived equally across this country. We know that it's well documented that Aboriginal peoples in Canada, that we experience inequities, specifically morbidity and mortality rates, incidence and prevalence rates, but we elected not to give you a litany of those rates today and give you a bunch of numbers. They certainly are available, but we do acknowledge certainly that chronic disease amongst Canada's Aboriginal peoples are on the rise, and it's no surprise to anybody in this room, I assume, that the rates of diabetes and rheumatoid arthritis, for example, are hugely escalated for this population compared to the rest of Canadians. Infectious disease, while the infectious diseases that we face today amongst Aboriginal peoples is not the same as it was 150 years ago, tuberculosis rates are certainly on the rise. It's still very much a live issue in where I come from. And HIV/AIDS is on the rise as well. So we acknowledge that there's lots of different morbidity and mortality rates that differentiates the different populations, but that's as far as we're going to go on that today. Why focus specifically on Aboriginal people? Well, really they represent a growing proportion of the population. I said I wouldn't do stats, but I can't remember the statistics off by heart, and I need my reading glasses. That in 2006, Aboriginal peoples in Canada represented 3.8% of the population. That rose to 4.3% in 2011. So with higher birth rates and longer life expectancy now, certainly the proportion of Aboriginal peoples in Canada is growing. Amongst those Aboriginal people, First Nations make up about 60%, Métis about 33%, and Inuit 4%. I think if you work, depending where you work, I think certainly in different parts of Canada, Aboriginal peoples make up a larger proportion of the people that we're seeing in the hospital settings. So it behooves us to talk about this group specifically. And certainly, as our essential competency profile outlines, one of our roles is as advocates. So we saw this morning as an opportunity to put on our advocate hats and think about how we can actually push this agenda forward on behalf of Aboriginal peoples across Canada. So we felt it also was necessary. I'm not sure what everyone's background is, but just there's one little slide, a little bit notes on terminology. We talk about Aboriginal peoples in Canada. It's certainly used very widely. It comes from the Canada's Constitution Act and the Royal Commission on Aboriginal People, that 5-volume big doorstop that is sitting on most people's shelves right now. Volume 5 is great on healthcare. If you haven't had a chance to look at it, it's excellent. But the term Aboriginal has been criticized by some people as being a reflection of colonization. That's the term that's used in the Constitution Act. So while some people use the term Aboriginal as an umbrella term across Canada, other people have criticized it as being linked to colonization. So generally in Canada, we recognize that Aboriginal is really an umbrella term, and people lose their identity within that term potentially, and that there is heterogeneity within the population groups. So generally in Canada, we talk about First Nations, Inuit, and Métis separately. The United Nations, they promote the term indigenous. And actually, recently I was reading some stuff from CIHR, Canadian Institute of Health Research, their Institute on Aboriginal People's Health. They're looking at changing their name to Indigenous. So it is a bit of a moving target, is bottom line. Terms such as treaty status, who has status, that has to do with how you're recognized under the Indian Act of Canada, and whether your population group, your family, your tribe was signatory to a treaty. So why is that important for physiotherapists? Well, if your personal experience includes trying to get somebody a mobility device under the Non-Insured Health Benefits Act, you know how important it is, whether you have treaty status or not. But in terms of Indigenous, what do we mean when we talk about Indigenous? It really, the United Nations, what they mean, they refer to communities, peoples, and nations which, having a historical continuity with pre-invasion and pre-colonial societies that developed on their territories, consider themselves distinct from other sectors of the societies now prevailing on those territories or part of them. Key words there, pre-invasion, pre-colonial societies, and that they're distinct societies. Those are the key words there. So that's it in terms of the introduction. One of the things we're very pleased to share with you today is the newest position statement of the Canadian Physiotherapy Association on the role of physiotherapy in Aboriginal healthcare. So this newest position paper, if you're a CPA member, which I hope and I assume all of you are because you're in this room, you received an email not long ago that actually announced this new position paper. And this was a result of initiative taken by physiotherapists, some who are Aboriginal and some who just feel very strongly about the health issues. We work across Canada, and we really wanted to promote a formal position to unify our concerns, and the hope was that this would be a document that we could use for further advocacy around human resources and new programs and services. So it was definitely an initiative from the ground up. It was approved in December. There was a background paper that had all the background literature and research that you need, and that was distributed through email just recently in May. At least it came to my inbox on May 16th and maybe yours. We do have some hard copies of the background paper at the back table if you wish, but it's also available online. All of this is online on at the CPA website, and if you follow the links for advocacy and position statements, you'll get the position statement and that background paper. And the background paper, which again had contributions from across Canada, Aboriginal peoples and people who are concerned around the issues, was entitled Access to Physiotherapy for Aboriginal Peoples in Canada. Great teaching tool if you're in the educational environment, or if you supervise students, I would encourage you to direct your students to these documents as well. And within that position statement, it clearly outlines the role of physiotherapy in Aboriginal healthcare, that the healthcare priorities should be identified by Aboriginal communities, not the experts parachuting in, but that these issues actually get brought to the forefront by the communities themselves, and that the priorities should be matched to the appropriate health professionals and funded to ensure the delivery of effective and efficient healthcare, the mantra of the right healthcare provider at the right place at the right time. This includes physiotherapy, an important component to the care of acute illness and injury, as well as the prevention and or management of chronic disease. So trying to link how physiotherapy can really be part of the answer in Aboriginal healthcare. And that through collaboration with our clients, including the communities, families, and other healthcare providers and funders, that physiotherapists can play a significant role in the service development and planning that is based on the unique and specific needs of the Aboriginal populations across Canada. So this is our position statement. This is hopefully our way of moving forward. And within this background paper, it is very clear that CPA, it recognizes the diversity of culture and history, health status and health needs of the different Aboriginal groups within Canada. It does provide a brief overview of some health status. If you want some statistics and some links, it's lots of references there for you if you like. And it does, on this not following the deficit model approach, but thinking more positively, it provides some wonderful examples of contributions that physiotherapists have made to improving health outcomes around the country, and along with information on barriers and gaps to quality care, again, specific to Aboriginal health. And so some specific examples of the gaps, some of which we'll address today, that there is limited access to rehab services related to lack of health human resources and that limited healthcare workforce. And we will be speaking about some of the initiatives that the universities have taken to try to address some of this. The lack of identification of rehab needs in the planning and implementation of healthcare services. The lack of standardization of access to PT/OT, it's mentioned school services here specifically, but I would also say all services really. That there's a lack of funding for transportation to rehab services by non-insured health benefits for those people living in remote communities. So how do we get people to the physio services? If the government won't bring us to them, how can we bring them to us? Where are some of the gaps in some of these supportive services? And the lack of culturally appropriate care to address the needs. And that's, again, something that we're going to try to address here today. And at that point, I'm going to turn it over to my colleague from UBC, Robin Roots.
Thanks, Moni. So the second part of today's talk is for us to just run through a number of initiatives that are happening across the country to give you a flavor of really how we're trying to embed some of the concepts in the position paper. So in 2012, the University of British Columbia took a look at our admissions process and tried to increase the amount of rural and Aboriginal health content in our curriculum. And so we decided we would look at what other universities are doing. We did an environmental scan across the country of MPT programs to look at how are they supporting Aboriginal students into the admissions process and in the program. So out of surveying 15 schools across the country, we found that 13 of those had a process during the admissions where applicants could self-identify. We know that this is not necessarily an accurate view of actually the number of Aboriginal applicants that may be applying to the program, but at least it was a start and a measure. We asked programs to tell us whether they had a separate admissions criteria or process for Aboriginal applicants and students, and we found that 3 universities across the country reserve seats for successful applicants who are of Aboriginal descent. One of the programs grants interviews to those who met the minimum requirement, and one of the universities has an affirmative action policy to help mitigate some of the challenges of Aboriginal applicants into MPT programs. We asked about the resources that might be available for Aboriginal applicants into programs, and we found that 3 universities offer support to those applicants during the admissions process. We also asked about resources for Aboriginal students in the program. And we found that the majority of universities across the country offer some kind of support, very often through the Faculty of Medicine, providing specific resources and specific supports for Aboriginal students embedded into the program. So to us, this was a good start and made us at University of British Columbia look at our process and ways in which we might be able to help support and encourage more applicants into our programs. Why is this important? Certainly, this is just a snapshot of what's happening in the US. We don't have data in Canada around this, but we certainly know that Aboriginal healthcare professionals make up a very small portion of our profession. Taking data from the US, we see that Aboriginal and in this case, American Indian and Alaska Native make up less than 1% of the total PT population. If we look at other programs, we certainly know that in medicine they've done an awful lot of work to encourage more Aboriginal applicants into medicine, and they've been able to kind of increase that up and reduce the number of certainly just Caucasian white physicians. We certainly are in parallel with a lot of other programs like OT, speech, audiology, so we certainly have a lot of work to do. I'm going to now turn this over to Arliss, who will tell us a little bit about what's happening in the curriculum.
Good morning. I am Arliss McQuarrie, and I live and work on Treaty 6 land in Saskatoon at the University of Saskatchewan School of Physical Therapy. And a little piece of my story to start with is that I think it all began for me in about the year 2000 when I was invited to participate in something called a passantia. I don't know if any of you have heard that term. It means passing through, and it's a common approach to community development, program development, especially in Central America, but in other developing countries. And it has with it the principles of mutual, respectful sharing of information, and therefore that kind of engagement that can allow for relevant community development. It was a big eye-opener. It was a retreat in northern Saskatchewan. There were people from Mozambique, Africa there, as well as other health providers, about 30 of us for 2 weeks. And we spent a considerable amount of time learning about appropriate interactive tools and to work with communities, and then going into the indigenous, some of the indigenous communities in the area. But anyway, what that did for me was create a passion for the need for sharing that kind of information, and especially helping students in physical therapy start to understand some of those principles as well. So my speaking today in my little piece has to do with what we're doing at the University of Saskatchewan in the School of Physical Therapy, for sure, but not me, several faculty members, and the importance we feel that in developing curricular content in this area. If one is going to do this, one has to have institutional support, and we are in the College of Medicine at the University of Saskatchewan, and the College of Medicine has, or the Canadian Colleges of Medicine accreditation process has a very strong mandate towards there being social accountability curricular content. So we participate in that as well. And the principles around that relate to development of goals related to including Aboriginal content and Aboriginal consultation, the consultation with Aboriginal communities. And aligning the curriculum with institutional philosophy meant looking very directly at a foundational document at the University of Saskatchewan, which is really important and which we use a lot, that speaks to engaging with Aboriginal communities in Saskatchewan. When we developed the curricular content, we conceived of, I guess, a pyramidal kind of concept where there'd be broad-based education very, very early in the program. Actually, it starts within the first 3 weeks of the program. So starting to learn things like broad definitions of important concepts, cultural concepts related to Indigenous peoples, and the history of the relationship, I guess, with Canadian governments with their Indigenous people, some of it good, some of it not so good. Things like residential schools in the 60s scoop, what has been helpful, what has not been helpful, all of that broad concept. And then gradually going up the pyramid and helping students in depth learn more and more about Aboriginal culture and engage with Aboriginal community socioeconomic determinants of health, for instance, in more depth. And so we integrated this in a stream throughout the whole of the 2 years of the curriculum very carefully. The consultation with Aboriginal Indigenous communities was, I'm using both terms, but was very, very important. And in fact, we have some consultants from both the Métis and First Nation communities who on a regular basis help us understand how to present this content, compose this content in a respectful and accurate way. And it has often surprised us when we compose something that we think looks very good and is right, and we ask people from the community about it, and the answer is no. Just words themselves can be very important, and the words chosen. So I would highlight this as a very important aspect for curricular development. And then there's the experiential learning piece, of course, too. So we do send students out into diverse models of clinical practicum. We would like to do more of it. Our resources aren't as much as we would like, but certainly we have students going into primary health kinds of activities which are not traditional healthcare clinics in PT, but look more at educational things and the health of the community. Just some examples of curricular content delivery. The 7 health sciences programs at the U of S do deliver an interprofessional module in problem-based learning that's called First Nation Culture, Health and Healing. And we've been doing this since 2001. We have 300 to 400 students per year go through this module with a case centered around an Aboriginal person from a northern Saskatchewan community. And the focus of the case is cultural aspects. It is not the biological components of that person's health, although that's a part of it, but it's not the focus. So we've evaluated this over about 13 years, and we evaluated quite extensively, and it's amazing. The evaluations from year to year are remarkably consistent. you could almost place them one on top of the other in terms of the students liking the process and learning from it. So just one example, one of the questions is, as a result of this exercise, my understanding of First Nation culture, health, and healing has increased. And we use a Likert scale of 0 to strongly disagree to 6, strongly agree. And across all of the 7 health professions with no significant difference, the mean from year to year has been 4.37, 4.67, 4.62. You can see the consistency over time, and all of the years will look like that. In the mean enjoyment scores of the students for participating in this module, over the years, anywhere from 5.03 to 5.24 out of a 6-point scale. So very high evaluative scores. And all of the evaluative questions tend to look like that, extremely positive over 13 years. Students do assignments to learn more about Aboriginal culture and, again, definition of terms and the history of Indigenous peoples in Canada. We also have 100% of our students actually try to experience something of the socioeconomic determinants of health by being exposed to the community. So we take them into the core neighborhood and do a day workshop in the community where they interact with people who live in the community and who've experienced many of the socioeconomic determinants which are challenging, such as addictions and poverty. Poverty receives special emphasis on that day. And they do a walk through the community with residential guides to better understand the strengths of the community, which are much more emphasized than the negative aspects. And that's it.
Don't go away, Arliss, though, because I think you're the one after this. So certainly, as Arliss said, at UBC, we have done a number of initiatives to try and provide that experiential learning for students so they actually can be in the neighborhood and can, in fact, see what the role of a physiotherapist is in First Nations health. And so in Northern British Columbia, as part of a Northern and Rural cohort, we have partnered with a number of First Nations organizations that deliver healthcare to bring our students into the community and have a chance to actually develop some of the competencies associated with providing culturally safe care. And so we've done that through certainly primary healthcare clinics, through interprofessional education opportunities, much like Arliss has already described, really providing students the opportunity to understand the importance of nation-specific culture, that there isn't a homogeneity to Aboriginal health, that it is very nation-specific, to really understand that historical context by being in the community and seeing the repercussions of colonization over time. Understanding what trauma-informed practice is when you're a physiotherapist and you're working in a hands-on profession with a population that has suffered an awful lot of trauma. So I can't speak to too much of this, but Arliss has already disappeared off the stage. So certainly this is, I think, some of the things that she referred to about the plunges and taking students into core neighborhoods. So I can't really speak to too many of these here, but you certainly have done an awful lot of work. And I think, if I can say, the University of Saskatchewan is miles ahead of many of us with regards to really providing students that true grounding in culturally competent care. I'd now like to turn it over to Hilary, who will now take us into the actual clinical context. Oh, perhaps after I've talked about accreditation standards. Thank you, Hilary. So certainly this all aligns with the accreditation standards that all the universities are held to, certainly around safe and protection rights of all individuals, enhancing that diversity, reflecting the diversity in clinical practice, demonstrating sensitivity, and now we've gone much further than sensitivity to really understand that it's about safety more than about sensitivity. Now I'll turn it over to Hilary, who will tell us about clinical practice. Thank you.
Thank you. So my name is Hilary Crowley, and I'm from English parents, and I live at Summit Lake in north central British Columbia on traditional Treaty 8 land, and I'm very happy to be here on traditional Treaty 6 land. Thank you very much. So I'm going to talk a little bit about community-based rehabilitation. I'm an itinerant pediatric therapist in small communities in north central British Columbia and have worked in community-based rehabilitation. So I want to talk about the challenges and opportunities of introducing community-based rehabilitation and the importance of building partnerships to improve access to services. In these small communities where I work, it's very difficult to recruit physiotherapists, but in the more remote indigenous communities, they've never had a physiotherapist, and so it's even more difficult to recruit there. Community-based rehabilitation has actually been developed right here in Canada, and Dr. Malcolm Peet, who was a previous CPA president, founded ICACABA, the International Centre for the Advancement of Community-Based Rehabilitation in Kingston, Queens, and it's widely used throughout the developing world in areas where they find it very difficult to recruit healthcare professionals. So community-based rehabilitation, CBR for short, is a strategy within community development for the equalization of opportunities and social inclusion for all people with disabilities. Some of the challenges include that very often in these communities, high school education is not available. And so it's very difficult for people living in those communities to achieve grade 12, which is usually a prerequisite for any college education, such as physiotherapy or rehabilitation assistance. I've already mentioned it's very difficult to recruit and retain local health personnel like physiotherapy assistants, and so the rehabilitation services are not available locally. The opportunities are that physiotherapists are very well equipped to provide the needed health and exercise programs, and we have new opportunities for both the clinicians and the students to provide innovative programs. That's outside Waiani Daycare, which is part of Lake Babine Nation in Burns Lake, north central British Columbia. So we've initiated a program in Fort Babine, which is in north central BC. It's 105 kilometers north on a logging road beyond Smithers, which is the nearest town. It takes 1 hour and 45 minutes to drive. Smithers itself does have physiotherapists, but this area is serviced for pediatrics by Burns Lake, which is about another 2-hour drive to Smithers and then an hour up. And I go from Prince George, which is another 4 hours from Smithers. So it's not easy to access this. So we decided to train local people in the community. And so we've been training the community health workers in rehabilitation services. So when we were building partnerships, we met with the Lake Babine Nation, with the Fort Babine personnel, such as the people at the medical clinic and at the school, and of course with the families of people with disabilities, with the College of New Caledonia, who's my employer in Burns Lake, who are funding the pediatric training for this program, and the Northern Cohort, spearheaded by Robin Roots, who's the clinical coordinator for the UBC-UMBC component for training physiotherapy students in the north, and also met with other health professionals like occupational therapists, speech-language pathologists, fetal alcohol spectrum disorder professionals. And I'd like at this moment to recognize Phil Shepherd, who's in the audience here, a newly graduated physiotherapist from Queens, who very happily accepted a position at Smithers, and he spearheaded a lot of this preparatory work in Fort Babine. Obviously met with Lake Babine Band to improve accessibility for people with disability. And the future plan is for more meetings with the Carrier-Sakani Tribal Council so we can expand this concept to other communities. This just shows where Fort Babine is. It might not look remote. It's right bang in the middle of British Columbia. But as some of you, or most of you are aware, the majority of the population lives within a few kilometers of the United States border, and there's actually more moose and bears living north of Fort Babine than there are people. The photograph, Fort Babine, is nestled on the other side of Babine Lake there, at the foot of Babine Mountains, and it's just showing the logging road that has to be accessed to reach this community. So in November of 2013, we met with the College of New Caledonia staff and the UMBC Rural Cohort Advisory Group, and also with the Lake Babine Nation. And then in January of this year, we had the initial meeting with the Fort Babine stakeholders. Phil performed a needs assessment which showed the need for this community-based rehabilitation program. And 2 community members were identified to be trained in community-based rehabilitation. We secured the funding from the College of New Caledonia for the pediatric portion of the training costs. And in March of this year, we initiated the program with a 10-week pediatric module, which will be expanded to adults when the funding is secured. We've met with the Lake Babine Nation, and they're interested in funding the adult portion of this program. And once the training is completed, then a physiotherapist will attend every 6 months to further assess the clients and develop the program. So just a few statistics. Smithers is 105 kilometers or 1 hour and 45 minutes on a dirt road away. Fort Babine is that distance from Smithers. The population of Fort Babine is only 95. The age range is from newborn to 78. There are 6 children under 5 in the community, and there's 8 children up to grade 5 in the school, which as far as that school goes. To attend school in the higher grades, they have to go to Smithers and stay in a hostel in Smithers for their further education. 7 children were identified with disabilities, and there's 2 adults with spinal cord injury that can only manage with wheelchairs, and there's several adults with MSK conditions. So you can see there's a great need for physiotherapy and rehabilitation services. I'll pass on. Thank you.
Hello, I'm Alison Jones, and I'm with the faculty at the University of Alberta, and I am of Manitoba Métis ancestry, and I've always had a sensitivity to Aboriginal issues. So when we were fortunate enough to get funding for our research, this really was very encouraging for me to look at the arthritis in Aboriginal people in Alberta. This was a mixed methods study, and that used provincial administrative data along with qualitative interviewing. And today I'll just present to you with the qualitative component of the study. But before I go on, just to put it into context, looking at osteoarthritis in particular in the First Nations here in Alberta, that there hasn't been a lot of work done in that area. There's been a lot done with rheumatoid arthritis. However, it's very interesting with osteoarthritis that the prevalence was twice in First Nations as compared to the general population, and this was for adjusting for a lot of issues. And this was also reflected in primary care visits, that there was twice as much visits with First Nations for osteoarthritis. However, when you look at surgical consultation, it was only 2/3 of what the general population was receiving. And it was even less for hip and knee joint replacements. That was only 1/3. So for the qualitative component, we interviewed self-identified Aboriginal people from Calgary, Edmonton, and the Siksika Nation, which is just southeast of Calgary. We also interviewed healthcare professionals, 15 healthcare professionals, and they range from rheumatologists to general practitioners to physios, occupational therapists, and nurses. And this is the framework that, from all those interviews, this is the framework that we proposed. And that what we were seeing was that there were different social contexts from the patient and the healthcare provider perspective. So what we were seeing with the frame of work, that patients were seeing or were describing putting up or accessing care for arthritis as toughing it out in respect to the pain, to the arthritis that they had, and this was a way of coping or looking at resiliency. there were competing comorbidities that they had to contend with, life events, and family obligations. So that's how the patients identified it. Now, the healthcare professionals defined it with respect to buying in, having the patient buy into the services, and that they found it frustrating when patients came and that they were coming at a delayed onset of the disease, that they weren't accessing the healthcare services as early as they would. So therapists were feeling, or the healthcare professionals were feeling a little frustrated in that respect, that if they could only see the person earlier, they could have helped them more. They were also frustrated with the missing appointments. They identified missing appointments, and it was seen as being missed opportunities. And so what we found here was that the expectations of the healthcare professionals were not congruent with the patient. So some solutions that we proposed was that, yes, the solutions can occur at the individual level, but I think within that framework that we presented was that it can also be, we should be sensitive to the systems level. And with that framework, as you can appreciate, that there were a number of systems that need to be dealt with when accessing care for arthritis. And that with the solutions, what they proposed, or what we proposed, was looking at cultural competency initiatives. In other words, being able to provide a safe environment for accessing health care. Also, too, a possible solution, too, is working around the system. And examples of that are on reserve specialty clinics. So what we recommended was this, that we present this framework that shows that it is very complex and that there are the views of the patient and the provider are not congruent, and that if we can understand some of these stances, that maybe we should be looking at some of these solutions and possibilities for easier access to arthritis. So that's a whirlwind tour of our explanation of the research that we were doing.
All right, it's me. I'm bringing up the back part of the program here. Thanks everybody for attending. I am Sarah Usman. I'm first generation Canadian. My dad is from India and my mom is from Wales, UK. I live on Treaty 6 land as well, and I'm a colleague of Arliss at the University of Saskatchewan. So I'm going to share with you today a little bit of the work that I've been involved in over the last number of years. Primarily working within a Métis context, but certainly more recently working within a First Nation, thank you, Hillary, context as well. And before I talk about some of the work that I've been involved in, I just want to emphasize how important it is, thank you, for us to acknowledge and integrate unique knowledge systems in the work that we do, and understand that our Western knowledge is different and distinct from Indigenous Aboriginal knowledge. However, we need to continue to build partnerships, which is what I've heard throughout the talk today, to be able to create new ideas and ways to move forward together to address health inequities and really promote health and strength and health outcomes. And the way that I've been sort of looking at how do we do this, how do we come together and work together to build new ideas and move forward together, and participatory action research is a methodology that I've applied to some of my work, where it's not actually that different from clinical reasoning in the sense where you might have sort of a broader research question that's broken down to smaller bite-sized pieces, and those are each action cycles, and you have a plan, act, observe, reflect cycle that happens, and that what findings happen from that action cycle catapult you into the next one, and so on and so forth from there. However, it's not clean work, it's very messy, and I've actually started talking about how this is actually a reflexive, iterative process that happens even within each action cycle itself. And I actually threw in the Métis symbol here of infinity symbol, which actually represents two knowledge systems coming together and sharing, which I think fits really well with some of the work that I've been involved in. And so what does this look like from a research perspective, looking at the community engagement? So I've spent a lot of time in the northwestern part of the province working with the community of Île-à-la-Crosse. And like I say, Métis settlement, and we've had many levels of community engagement from sort of the governance level of mayor and town council, schools and health region, and then working directly with participants and community members. And what we've done is try to figure out how to actively engage participants in the project so that they have some of the control over the data that gets collected. And I could talk for a long time, but I have like literally probably 2 minutes left. So one example is using Photo Voice, where we gave young kids, grade 3, 4 students, cameras and asked them to take pictures of things that they did in their spare time and things that they ate. And this is just a really, I think, a really good example of some of the work that came out of it. And this little girl, his quote was, "My grandma makes bannock every day after school." And she had some learning challenges herself. She was living with her grandparents, and the baked, fresh, warm bannock after school was more than just a snack. I think it represented so much more of warmth and love and care that she was getting from her grandparents. And from some of the, excuse me, I really do need a drink of water, sorry. Some of the statements that came out of some of these young kids was really profound, I felt. So this was one of them. And it really pointed to the importance of understanding the role of children in the health of adults and vice versa. And so it led me to start thinking and talking and learning more about intergenerational approaches to health promotion. And I know there were some stats that were discussed earlier in the session. And between 2001 and 2006, as we all know, we in general in Canada have an aging population. And I think during that time, there was a 12% increase in the number of people who were aged 65 years and older in Canada. And during that same time, there was a 45% increase in the number of Aboriginal peoples in that age group. And what we also know is that the number of chronic health conditions that are experienced by individuals aged 65 and older are even greater among Indigenous populations. So we're trying now to take a peek at what can children do to impact health in the older Aboriginal population and in some of these communities, and vice versa. What do older adults actually do to impact the health of the younger generations, and build on some of the strong community structures that exist. So yeah, and I'm just going to end with this slide for my part of the talk and talking about cultural safety and how do we build cultural safety into our health system. How do we get around some of the issues that we've talked about with access and timeliness to care, and making sure that individuals do feel comfortable entering our health system. As PTs, we probably experience this a lot, that we're seeing people who come in, Indigenous people who come in, who are more unwell, and they wait longer to come in. And we need to understand, well, why is that happening? So this is where I really believe, and some of the dialogue I've had with colleagues at the University of Saskatchewan, is to understand how research, practice, and curriculum actually cross. And can we come up with different ways, experiential ways of providing opportunity for students to go into communities and experience some of these firsthand, social determinants of health and some of that. And I actually have 2 students sitting in the audience today who are smiling at me, who will be going up this summer to Northern Community under the umbrella of my research program, but piloting mini interventions, working with the older adults in the community of Île-à-la-Crosse to try and just have more of an experiential understanding of the realities of what people face in this community. And I know that through conversation with the panel of individuals, great individuals, by the way, who I've never worked with before, and there are other opportunities like this happening in other jurisdictions. I know at the University of British Columbia, they're looking at how to explore some of these experiential contexts. So I think, the momentum is building, and I will leave it there. And yeah, hopefully we get some nice dialogue at the end if we've got some time. So I think Robin's going to wrap it up. Or Moni? Yeah. Thank you.
So what our goal was to give you a snapshot of some of the positive initiatives that are happening across the country, but we also want to leave a little bit of time, and I think we have 5 minutes. So that's not bad, really. I mean, given the fact that we were partnering across 4 different provinces and trying to pull it together, I think we did not bad. Yeah, that we didn't totally run out of time. So what we're looking for from you is whether you might have any questions for us, yes, but if you have any stories of success, I think generally some of the questions that I get from colleagues is, how do you promote these partnerships? How do you get the networking started? And so if anybody has any experience stories that they want to, positive success stories that they want to share, we'd really appreciate it.
Hi, my name is Kate Rex. Is this on?
We can hear you.
You can hear me.
Small room.
I am new to the Canadian Physiotherapy Association as the Manager of Policy and Government Relations. And on May 15th, there was an announcement by the Federal Minister of Health that they will be doing a review of the non-insured health benefits. I'm part of a working group with a number of other professional associations at the national level to identify and understand where the challenges are with the non-insured health benefits program. And I would be very interested if anybody would like to talk to me in having sort of some feedback on what the personal experiences and the challenges are from the practitioner or the professional level, but then also if there are community stories that can come forward about what the barriers are to actually understanding and trying to reach out to get the appropriate care that communities need. So thank you.
So, well, that could be an hour-long discussion. I think you have a lot of passionate people around the room who want to talk about NIHB. Your name again? Kate Rex. Where would we find you? Do you want a coffee with a bunch of people who are interested?
Absolutely. My email address, I'll give it, or if you want to come up to me afterwards, please share contact information. I'll put together even sort of a group email list so that I can update on what the progress is for the working group. My email address is KREXE.
Okay, hold on. Look at this. KREXE.
At physiotherapy.ca.
There we go. That's right? So, and there's a break right after this before the next presentation, which some of us are involved in as well, but maybe we could just attack you. Okay, we have many stories and many things I think we could share with you. Yes?
Hello, my name is Rosamond Smith. I'm a physiotherapist working in Fort McMurray, and
Very good.
we service. Hi, Hilary. I've known Hilary since I first came to Canada 35 years ago. I've been fortunate to work in Fort Chipewyan, which is a flying community, for 3 years, flying in on a Tuesday morning, doing clinic, staying overnight, and clinic and flying out the next day. The community is accessed by road during 3 months of the winter, but it's too far to drive for people, although some people will come down and take some treatment in Fort McMurray, but it's hard when you've got to soar back to go on an ice road for 4 hours.
On a very bumpy ice road.
Yes, it is. But also I do spend 2 days a week in Fort Mackay, which is just north. It's only 45 minutes north of Fort McMurray, but it is fairly isolated. It is in the center of the oil sands, surrounded by a lot of big companies. So the Fort Mackay First Nation have taken advantage of a lot of business opportunities, and they're quite a wealthy band, and they pay for us to come twice a week. And we work in the health centre there with Dr. John O'Connor, and there's always a nurse.
Your
there.
services are community initiated.
Yes.
That's excellent.
As Dr. O'Connor, I have to give him a lot of credit. He sees the need, and he knows that we need to be in there helping. It reduces the amount of medication he has to prescribe. So I see people. We have a small room with a couple of beds and some modalities, and there's a gym in the basement of this band hall, so we use that. And then I go and do home visits for elders who are not able to come into the facility. So that's just a model that I feel is working. It's great to be part of the team. I'm also working with a community health person. We're starting to get an arthritis support group going, And as long as we provide food, people come. And
So, you know, thank you for sharing that. I would say that we probably have a lot more stories in the room, but we are out of time. It's 10:06, and you know what? Stick around if you want to keep sharing stories. I do just want to end it by acknowledging again the Global Health Division for inviting us out today, thanking you for sitting through in the audience, for hopefully what wasn't too disjointed by having so many speakers with different topic areas. We have some feedback from CPA. They want our feedback on uninsured health benefits. Thank you to Carol Miller and CPA for putting out the new position statement. Remember that the background paper, there's hard copies at the back if you'd like one. None of us want to take them home with us. I want to thank or acknowledge my niece, Katie Sibinel, who did the illustration for the talking stick, and acknowledge the Coast Salish talking stick that was carved by Jim Yelton. If you want to take a closer look, it's up here. It's quite lovely. And certainly we want to acknowledge Rose Marshall for sharing with us today. Thank you.